Hi, it's Justin Shore from Chronicles of EMS with another 60-second life-saving tip. So you've called 911 and the paramedics are here. Now what do you do? Well, first off, take a deep breath and relax. Be ready to walk and talk. As you're leading us to the person who's ill or injured, tell us what's going on, what's been going on, and the reason that led up to you giving us a call. Also, before we get there, do me a favor. Have the kids in the other room. If you can, call a neighbor to come and watch them. Chances are they're now awake because of all the lights and sirens. Before we get there, also move the dogs into the back room. It's a lot easier to deal with their crying and yapping from the other room, as opposed to trying to keep them back from your family member that's injured. Gather their medications, or if it's you that's sick or injured, gather your medications and have them ready for us, along with any information about your physician and your medical conditions. If you can't move a dining room chair from your dining room set down the hallway, we can't get our equipment down there either. Keep that in mind when you're rearranging the rooms. Take a deep breath. Everything's going to be just fine. Until next time, this is Justin with another 60-second life-saving tip. So, gentlemen, we're here, Chronicles of EMS, seated at the table. We're going to talk about some things. We've got an online audience in the chat room.
Yeah.
We're going to be talking with them too. EMS 2.0. We've talked about it a few times on the blog. I got a couple emails saying it just seems like a couple of us that think we know what's going on, just kind of lifting each other up and not really doing anything. Do you think EMS 2.0 is going anywhere?
I think EMS 2.0 is going somewhere. I believe in it thoroughly, and I think that we have to, as a profession, take ourselves into the next level because nobody's going to take us the direction we want to go. We're going to have to be the ones that elevate our profession to what we need it to be.
Well, you're saying where we want to go. Do we know where we want to go? Do we want to be like Mark and go that direction? Be it the way his system is, or the way, National Health Service, or are we talking about clinical skills, or both?
I think we need to take the best aspects of what he does and what we learned from the original project and what you guys have done before, and put that with the best aspects of what we're doing. Other than I don't want to wear a green jumpsuit.
I agree.
I really like what I'm seeing with the respond, not convey, and the primary care aspect that they're doing in the UK. Mm-hmm. We need to adapt that and make that our own. How we're going to do that is a discussion of a lot of debate.
Yeah, and I don't think it'll come just from us being on the floor. I think it's going to need to come from all directions. Mm-hmm. But the one thing I like about the term EMS 2.0 is it not only denotes, moving things forward and kind of a reboot, but it's also an easy way to Google and find out who's talking about it.
Absolutely.
Lots of people around have been talking about it. It's an easy way to kind of gather people's ideas for change.
Mm-hmm. And right now there is a lot of talk, and I will say that there's been a lot of talk and not as much action as there could be. However, that's good because we have people talking now. Mm-hmm. Instead of having a few people talking in some small corners, we have a lot of people talking. We have a lot of people sharing their ideas on where we think we should go. And that discussion is what's going to bring out. We've had such a lack of interest from, I don't want to say it's apathy, because it isn't, but we've had such a lack of public discussion. And that's why this is going to work, because we are talking.
But we're so involved in it, and we've been talking about it for so long. We have our ideas of what's required over here and over in the UK. I think that's an important thing because we are doing this across different countries now. Mm-hmm. It's not just about changing the American healthcare system, because it's about changing the healthcare system, the pre-hospital healthcare system around the world. Mm-hmm. And we've had these discussions in person on our blogs and stuff, but what I would be interested in is hearing from you two. You've said there's so many ideas that we could change, but what are the sort of things that you actually see that would elevate EMS in America, in your state and in this state, to that different level? What needs to be done?
I think we need to get more abilities back in the hands of the paramedics. Mm-hmm. It seems like it's always been the physicians decide what we do and then just kind of kick us out with our licenses and get us working. Mm-hmm. But more and more I'm starting to see that there's kind of a disconnect between the physicians and the paramedics on the street, in the patient's bedroom at 3 a.m. in the morning, like I like to say. If we can get more clinical decisions made between the paramedic and the patient, where the paramedic can kind of move the system around a little bit to best benefit the patient. I think that's got to be the first step. is try to get not necessarily more skills, but more options for our paramedics rather than transport, don't transport.
The American paramedics have become really proficient at skills. We can stick IVs and more or less intubate with the best of them. We need to have the background knowledge to make the decisions that fit into the total spectrum of healthcare, because that's what we are. We are the primary healthcare and safety net for so many individuals that don't have the option to go to a family doctor, to go to an urgent care clinic, and they call us when they have nothing else to do. We need to be able to have the tools to fix that problem. Right now, we're pigeonholed into our role that we covet, our emergency healthcare role. And we need to be able to take on more of responsibilities for giving the patient their best options. You know, we'll never be the solely responsible for anyone's health. That's up to the individual and up to the patient, of course. But if we can give them the tools and then help them to make the best decisions, that's where we need to go.
But it's complicated. It seems an easy step to make. You know, like I said in the Chronicles first episode, we all think the same thing when we see our patients. You know, if I go to a patient who doesn't present with a clinical need, I'll be thinking exactly the same that you guys do, as in they don't need to go to hospital, I want to do something else. But in the trainings, the basic training's already there, because we all think that way. Some places don't have the background education to the required level to allow them to do that.
That there are paramedic schools in this country that will get people in, take their money, and get them out as soon as possible, just to get some more fresh meat on the streets.
The 6-month Magic Medic programs.
Exactly, where they teach you the color of the box of the medicine they're supposed to give. It's not good for the service, it's not good for the profession, but for the industry it makes sense. This constant, never-ending stream of people willing to work for low pay because their education is low. Do we need to start educating new paramedics better? Yes, but how do we take the people that are passionate about it, that want to do the right thing, that are trained now, and get them working?
Well, speaking not on the litigation aspect, because the first time we let somebody stay at home with a headache and they end up having a subdural hematoma, that's going to be an issue. But if you go out to my area, out to the rural areas, it's hard to keep a paramedic in our area. We don't have very many options for primary health care. We don't have many options for health care. And the ambulance is the stopgap measure for people, just like it is here in the city. But even more so, it's the stopgap measure. When they absolutely don't have an option, they'll call us. We need good paramedics for our hour-long transport time, but they're all looking to get a better job, a higher-paying job in the big city. To stay a rural paramedic is to turn yourself into a subservient, poor person for your career, and that's very hard. We're going to ask these people to get a bachelor's degree, which would be my goal, and then say, you're going to stay here in Podunk and make $10,000 a year. Good luck with that.
Yeah.
And that's something we have to address. So we have to look at our business model and figure out where other sources of revenue can come in more than just the fee-for-service and the transport revenue model.
But that's as well, that's moving away from, to encompass everything that we're talking about, it takes it out of 911 changing from an emergency service to having an emergency and an urgent care service type, all encompassed in one model. What we've just recently done over in England and North East is, we, as well as 999, we've got a pilot for a 111 number. And so anyone who has a medical need, whether it be urgent or emergency, comes through our control centre, and then it's triaged and dispatched for a paramedic to go. And then from there, we have all these avenues now open to us that we can move people to the right place to the right time, and at the right time to the right person.
Yeah.
You know, and it's working very well. But everything that I see that I would love to see change over here, it just seems to get to a point where, well, how could that ever happen? You know, and what you're talking about with your department and stuff, and possibly changing your role slightly to encompass something what you saw in England, then I can't wait to see how that works.
Yeah.
But you're still going to be limited without having to, yes, you can go out and you can assess someone and think they don't need to go to hospital, or you can chuck them in the back of the car, but until you've got the options there to move on, then it's sort of a half-hearted measure.
Yeah, there's three big speed bumps. I won't say they're walls, but speed bumps to trying to be able to do not necessarily what you do, but something that's better for our patients. Number one is this idea of liability. Like Chris mentioned, you know, the first time somebody with a headache, we refuse service, and they go and it's a subdural and they die. Well, that's already happening.
Yeah, but
When-
that has to be
That's
accepted.
already,
That's
that's
gonna
already
happen.
happening when we have delayed response times, when we have paramedics that aren't doing the right thing. If we train these people properly and go out, and I like to think I'm trained to a point where I could learn a little bit more. We always need to be learning, but if I can be trained to recognize that and not leave her in bed when there's indications that it might be something else, that's going to be the key. But this idea that there's going to be an increased liability, we have the same liability, we're seeing the same people, we're just giving them different options besides that overcrowded emergency room where they're going to triage her to the waiting room and the subdural is going to hit there anyway. So the liability is already there. Number two is going to be, I hate to say it, but the labor unions. I'm a union member. They take very good care of me. They speak on my behalf to my department and my city. But unions are notorious for trying to keep things streamlined, trying to keep more money in the pockets of their members, which is their job. The same way a corporation tries to make money, a union tries to keep money in the pockets of their people. So trying to tell a union that all of a sudden we're going to need to send 266 of your employees through a bachelor's program so that they can become advanced paramedics and we can serve the community better. Where's the money going to come from? The union's probably going to stand in the way of that until it's either revenue neutral, it doesn't cost their members, or there's some sort of benefit for their members, increased pay, whatever. The third speed bump to it is the for-profit for transport model. Private ambulances don't make money if I leave Irma at home. And if a municipal service picks it up and I start leaving Irma at home, there's still no revenue coming into the city and there's no way to really justify that expense. So how do we take these three big speed bumps and somehow squash them together and make people realize that those three things are not good for the patient?
If any corporation, any business that exists to have a cash flow and pay their employees, if they said we have these hurdles to our business, they would find a way to survive or they would go out of business. These aren't challenges that are insurmountable. For liability, and I'm not a legal expert by any stretch of the imagination, but I see the way we avoid liability as trying to wash our hands of it. And we push liability as far as we can away. We push it onto the physicians, we push it on the EMS system, we push it on the hospitals, and try to wash our hands and avoid getting any on us.
Yeah.
That's the way we handle it. And we do that by always being absolutely as safe as we can. And I'm still saying we should be as safe as we can. But if we try to defer the liability saying, I had knowledge, I was educated to this standard, I performed this wonderful assessment, and based upon knowledge and best practices in medicine, this is why I made my decision, we could defer the liability through knowledge and education and proper practice rather than I'm just going to transport him and let the physician deal with it.
Well, that's what happens with us. You know, it hasn't happened to me yet, but as part of our training to allow us to leave patients at home, it was said to us explicitly, if you do this over a long enough time, one of your patients is going to deteriorate and die after you've left them at home. It's just life, you know, and it comes back to exactly what you've said. If you show on your patient report form that due to the patient presentation, your clinical assessment, their observations on scene, and then always the get out at the bottom of if you feel poorly in any other way before you're transferred onto someone else, you call us back. If everything is right, then you know I've done my job and I've given that patient the best care and the best advice that anyone would have given them at that time. But sometimes bad things happen to good people, and that has to be accepted. But it has to be accepted by the medic, but it has to be accepted by the service that you're running for. And I'm involved in cases where things have gone wrong as a member of a panel that discusses these things. And the support has always been there for our medics as long as that patient report form is perfect and you can show that at that time the patient was fine.
Yeah.
You know, but it's a hard thing to accept, and it's a hard thing. It's a big jump from the days of, and this is my devil's advocate bit, as far as EMS 2.0, there's still people out there who don't believe we should be progressing like this. You're an ambulance man, therefore your job is to pick up that patient and take them to there. No more. You know, and it's easy for us to sit here and discuss this like this, and the people in the chat room and the people who are following the chronicles, because they're like-minded to us. You know, they want to see us move and they want to be involved in this sort of thing. But we're only touching a small fraction of the people who need to know, because we're touching the people who are passionate about it, who read blogs, who look into things further, who want to see the profession progress. How do we reach everyone else who is just riding along and doing the minimum?
I think not only just word of mouth and, you know, leaving your laptop open on the Chronicles site and walking away and seeing who looks at it, but I think the more important thing is that the people that are paying attention to what we're doing, the people that are going out, getting their education, you know, looking at websites, just seeking out as much as they can about their new profession. They're the ones that are going to be climbing the ranks in the years to come. These are going to be the EMS lieutenants in the street. These are going to be the administrative captains, the trainers. Those people are going to be in positions to influence how their system works. I hope to be in a position like that so I can make my service better for my patients. I can't do it from where I am now. But if we set the framework, if we start here, get our ideas out, we're all communicating all over the world. We're sharing ideas, we're sharing best practices. I mean, it can only get better from here. And when the people that are following us, or the people that have good ideas, become the decision makers and start implementing some of these good ideas,